Good morning and welcome to Assessing School-Based Practices to Address the Needs of the Whole Child. We are beginning each session with a brief look at the whole child, so you're not in the wrong session. We will get to our slides in just a minute, but again, even though we're talking about the whole child today, what we would like to do is just be thinking about the whole child as we go through this school year and how we can meet the needs of that whole child. And so moving forward in teaching, this is one of my favorite quotes: you can't do the Bloom stuff until you take care of the Maslow stuff. And so we really have to be thinking about the not only the academic needs of the child, but the social emotional needs of the child also. It comes from the Science of Learning and Development Alliance, a deep focus on building strong relationships, fostering a sense of belonging, and attending to social, emotional, and cognitive development is not a conflict with efforts to accelerate academic learning. These strategies are mutually dependent and reinforcing. And I think that that's an important quote because, again, they're mutually dependent on one another. So we can't just look at the academics of what the child's doing, but we also have to attend to those social emotional needs. This comes from A Nation at Hope. Some of you may remember back in the 1980s, A Nation at Risk came out, which changed some of the things in schools pretty substantially. And this is a new document that came out called A Nation of Hope. And this is addressing the social, emotional, and academic development of our kids. A Nation at Hope, there's a remarkable confluence of experience and science on one point. Children learn best when we treat them as human beings with social, emotional, as well as academic needs. And so, I think that I hate to say that we have to treat them as human beings, because I would hope that all of us would treat our students as human beings. But again, some people, don't consider those social emotional needs and are just considering those academic needs of kids. And we really have to look at that whole child. The second quote says, the promotion of social, emotional, and academic learning is not a shifting educational fad. It is the substance of education itself. It is not a distraction from the real work of math and English instruction. It's how this instruction can succeed. So again, we have to take into consideration the whole child when looking at academics and how kids are performing academically. What is the whole child? In our presentation, we're gonna look at this a little bit more closely. But educating the whole child cannot be reduced to a simple set of policies or proposals. It is instead a mindset that should inform the entire educational enterprise. So again, this comes from A Nation at Hope and just reinforces again that we have to think about the social, emotional, cognitive, character, physical, and academic needs of the child. And so again, this is just a brief introduction so that we think about the whole child throughout our session today. This is actually the intro to all of our Summer Blitz PDs. And so we're going to ask you to just think about that throughout today's session. And there's my contact information if you'd like more information. So now we're going to get on with assessing school-based practices to address the needs of the whole child. Again, I probably should have introduced myself earlier. My name is Cindy Cook. I'm a school health consultant at Wayne Risa, and my partner today is Heather Rottermond, who's an assessment consultant at Wayne Risa. So we'll be your two presenters today. So again, there's our contact information if you're interested in getting a hold of us, both our email address and our phone numbers. Today's resources, if you'll take just a minute, to go to this tiny URL. We have resources in there that we're going to be asking you to use today. And so if you would be so kind to take a couple of minutes and go to that tiny URL and just preview some of the content that's in that folder, I think you'll find it helpful when we do ask you to go to the folder again. This is an opening activity that we like to do. And I realize that we are not in person today doing this training. And so if you'll just take a minute to kind of look at this. This is a nice opening for meetings and stuff like that, just to get a feel for where people are. And it says, finish this sentence. The blob number that I feel like today in relationship to starting school in the midst of COVID-19 is number, and then why. And we're going to model. So I'll go first. And I'm kind of feeling like number 10 today. We've had our struggles with online learning. All of us have, with the pandemic that we're in the midst of. And I'm kind of feeling like, okay, I can get this, I can handle it, and feeling pretty good about where I'm at. I don't think I'm at 20, but at least I'm at 10 at this point. Heather?
So the blob number that I feel today in relation to starting school in the midst of COVID-19 is number 11 or 12. And you can kind of see that they have their arms around each other. And as we return back to our office settings, even just being with colleagues and recognizing that other colleagues might need that hug, or maybe that like 6 feet away hug. I think that just reminding each other that we need to continue to lift one another up as we navigate new spaces, as we all return to a school setting or a workplace setting.
Thank you, Heather. And so just take a minute to look at that and contemplate where you are and how you're feeling today, and just recognize that and be with that feeling as you are. So our objectives today, discuss Medicaid programs for students and families. And I just do this simply because I am funded through Medicaid dollars to do some of this work. And so we like to just talk about that very briefly. There's a pre-assessment activity. We're just going to do a few questions. We would do this in a polling if we were live, but we're just going to go through the questions today and have you contemplate those questions very quickly. Then we're going to examine the origins of the whole school, whole community, whole child model, or the WSC model as it's sometimes called. We'll describe the components of the WSC model. We'll describe the link between health and learning. Recognize the value of using the model to impact student achievement. And then we'll reflect on current practices related to the WSC model, data collection and data analysis. And we're going to explore some case studies of where strategic implementation of the Whole Child Initiative has been successful. And we're going to ask you, that's when we'll ask you to go to that tiny URL and pull up a couple of case studies. This is the My Child and Healthy Kids application. Again, we have 2 programs available in Michigan for students that may be uninsured or families that may be uninsured. And so if you do know that some of your students are struggling with that, we have My Child and Healthy Kids. It's health, the My Child is health and dental care for children under the age of 18. The premiums are $10 per family per month. Not per child, but per family. And that's administered by the Department of Health and Human Services. And then Healthy Kids is health and dental care for pregnant women and children under the age of 18. And there's no monthly premiums for that particular program. And it's also administered by the Michigan Department of Health and Human Services. The nice thing is that you can fill out one application online, and the department will decide which of the programs you qualify for. I did hear from a teacher one time that was pink slipped for a short period of time, and her kids played hockey, and she wanted to make sure that they had health insurance. So she signed them up for one of these programs and said it was absolutely wonderful. The hardest part was getting them off of the program once she was recalled back to work. So again, 2 good programs if you have kids that are families that are uninsured. And this is just a brief video we're going to show you about some mental health resources for teachers, because again, we have to be aware of our mental health during this period, as well as our students' mental health. And so let's just take a quick look at this video to see what resources are available at the state of Michigan.
the COVID-19 pandemic, we've been asked to adapt to many changes. And there are many questions that still remain unanswered. And with all the change, we are responding sometimes with lots of emotions. Many people are experiencing reactions emotionally that are similar to traumatic circumstances. There may be confusion or worry or exhaustion. It's important to maintain balance as we experience these emotions. One way of doing that is taking care of our bodies. For example, getting a good night's sleep can be incredibly important for our mental well-being. Trying to go to sleep every night at a certain time and clocking the right number of hours is important. Remember to try and sleep in a nice, quiet place where there's limited distractions and noises. Also, try to avoid alcohol and caffeine right before going to bed. Eat a balanced meal and get exercise. And if worry and depression is overwhelming, call a healthcare provider. Also, if you want someone to talk to or to chat with for emotional support, go to michigan.gov/stay-well for a number of resources. Remember, our mental health matters just like our physical health. Pay attention to it, and thank you for listening.
And so I encourage you to check out michigan.gov Stay Well website, because it does have a lot of mental health resources. And again, the point that she makes at the end is very important, is that our mental health is just as important as our physical health. And that goes for teachers as well as students, staff members as well as students. And just remember that that's available to you. Okay, so these are your pre-assessment questions. Number one is, I am familiar with the whole school, whole community, whole child model. And that's just a yes or no. You know, are you familiar with it? Have you seen it? Do you know what it is? Number two, I know the two organizations that promote the WSCC model. There are two major organizations that promote it, and I'm just wondering if you know who they are. Number three, I can name 3 of the 8 components of the Coordinated School Health Program or of the WSCC model. And we'll talk about that a little bit further. Number 4, I can name 3 of the 5 tenets of the WSCC model. So again, if you're not familiar with it, you probably can't do these other ones, but if you are familiar with it, you may be able to. Number 5, I'm familiar with the Healthy School Action Tool, which is a needs assessment tool that can help you in implementing the whole school, whole community, whole child model. Number 6, I'm familiar with the Michigan Profile for Healthy Youth, or the MIPHY, and we'll talk about that. And number 7 is, our school or district consistently collects data around the whole child. And we'll be asking you, Heather, a little bit later on in the presentation, we'll be asking you what types of data you are collecting around the whole child. And you may be collecting more than you think you are. So the ASCD, in answer to the first question or the second question, the ASCD is a leader in the US and in education. With over 140,000 members in more than 138 countries. And so these are the big education people. In 2007, the ASCD Whole Child Initiative changed the conversation about education from a focus on narrowly defining academic achievement to one that promotes the long-term development and success of children. So in 2007, the ASCD came up with the Whole Child Initiative, saying we can't just be concerned about the academic outcomes of the child, we have to be concerned about other aspects. And so this is what they said in 2007. We challenge communities to redefine learning to focus on the whole person. We encourage schools and communities to put aside perennial battles for resources and instead align those resources in support of the whole child. Policy, practice, and resources must be aligned to support not only the academic learning for each child, but also the experiences that encourage development of a whole child, one who is knowledgeable, healthy, motivated, and engaged. The second organization that is advocating for the whole child model is the Centers for Disease Control. who we've been hearing a lot from lately in this pandemic. It's our nation's leader in health promotion and disease prevention. In 1987, so this goes back to the 80s, the CDC developed the Coordinated School Health Model. And that has helped to establish health promoting policies and practice in schools and districts across the country. So it's these two organizations that came together. And so in the next slide, the CDC in sum, if American schools do not coordinate and modernize their school health programs as a critical part of educational reform, our children will continue to benefit at the margins from a wide disarray of otherwise unrelated, if not underdeveloped efforts to improve interdependent education, health, and social outcomes. And we will forfeit one of the most appropriate and powerful means available to improve student performance. And so I really see this speaking to comprehensive school health. And when we talk about comprehensive school health, we talk about that's K-12 health education, having health education in each one of those grade levels that examines, what we should be doing to stay healthy. So this is just a brief history. In the 1980s, the CDC introduced the Coordinated School Health Program, which we'll go over in just a minute. 2007, ASCD introduces the Whole Child Initiative. The CDC and the ASC came together in 2014, and they came up with the Whole Child Model, WSC model, Whole Child Model, or Whole School, Whole Community, Whole Child Model. And so basically what this does is that we know that if kids are healthier in the classroom, physically, mentally, socially, emotionally, they're going to have improved academic performance. And so there's a very close relationship with the two of them there. And we have just a couple of quotes from the Carnegie Foundation. Clearly, no knowledge is more crucial than knowledge about health. Without it, no other life goal can be successfully achieved. And that was in 1983 and still holds true today. The next quote comes from the U.S. Department of Education, and it says, "Too many of our children start school unready to meet the challenges of learning and are adversely affected by drug use, alcohol abuse, random violence, adolescent pregnancy, AIDS, and the rest." And again, like the next slide shows, is that it's very difficult for our kids to be successful in school if they're hungry, stressed, depressed, tired, being bullied, sick, abused, so on and so forth. And so that comes from ASTO in 2002. And we just have to realize that if our kids aren't feeling good in school, that they're not learning. So we'd like you to take a minute to think in ink here. What's your experience been with the whole child? All right, so just take a minute to jot down some of your thinking around your experiences with dealing with the whole child model. So this is the whole child model. Number one, it places the child at the center of the model because that's what we're focusing on. It takes a comprehensive approach to supporting learning and health, and we'll talk about how that happens in just a minute. And it calls for greater collaboration across all sectors, meaning the community and the school and the people, the stakeholders in the school. What's the definition of the whole child? Let's make sure that we're all on the same page when it comes to defining what the whole child or who the whole child is. And this is Michigan's definition of the whole child. It says the whole child is a unique learner comprised of interactive dimensions such as cognitive, physical, behavioral, social, and emotional. The whole child lives within multiple and interconnected environments, including home, school, and community. So that's the Michigan definition of the whole child. And again, not just taking that cognitive aspect, that academic aspect, but expanding it out to look at the physical, behavior, social, and emotional aspects of the whole child. This is the Coordinated School Health Program. And if you notice, if you look at these components very quickly, what you'll find is that most of these components are already present in schools. When the Coordinated School Health Program was developed, it wasn't meant to be expensive or time consuming. So you'll see you've got comprehensive school health education, you've got comprehensive physical education, school health services, nutrition services, counseling, psychological and social services for students, a healthy school environment, school site health promotion for staff, because again, we're not only concerned about the health of students, we're concerned about the health of staff also. We have to be mentally prepared to go into that classroom every day to do our best job and to serve the kids as best we can. And then we have the family and community involvement. And those are the 8 components of the original coordinated school health program. What has happened is that they took the original 8 components and they expanded it to 10. And they split up the physical environment and the social emotional climate, because those are 2 very different things. The physical environment is how the building looks, you know, is it clean? Is it, you know, well representing of the school system and so on and so forth. Whereas the social emotional climate, you can feel when you walk into the school. You know, are you welcomed at the desk of the secretary when you come into the school? Do you see kids and teachers talking to one another in respectful ways? And so that's that social emotional climate. And then what they did is they split up family engagement and community involvement, because those are 2 very different things also. Family engagement is engaging families, whereas community involvement is involving, you know, community members, perhaps to provide resources to the school. And again, we included this because this is one of my favorites. Again, we have to remember that students must Maslow before they can bloom. So we have to be thinking about those components of Maslow, which we'll go over in just a minute. And so what the coordinated school health program and the WSC model is all about is getting each of these components, which again, I said, for the most part are already there in schools, and getting them to talk. All right, so if we're not talking right now, the right hand doesn't know what the left hand's doing. But if we can get just a little bit of talking going on, we start to build a safety net for our kids. And so in the next slide, you see that, again, we've got a couple of components that are starting to talk to one another. And we go to the next slide and you see that we've got a few more components starting to talk to one another, starting to develop that safety net for kids. And then finally, in the end, when you've got all of the components talking to one another, we really have developed a safety net of programs and policies and procedures that are going to make sure that fewer and fewer kids fall through the cracks. And that's what the 10 components are for. The 5 components, the ASCD tenets, are that our kids are healthy, safe, supported, engaged, and challenged. And so if we have those 10 components talking with one another, our kids are going to feel these things in school. And so that's the whole idea behind the whole child model. And so this is actually how the tenets read. And you can see that students enter school healthy and learns about and practices a healthy lifestyle. The second one is each student learns in an environment that is physically and emotionally safe for students and adults. So not just physically, but emotionally safe also. So kids can take risks in classes. So if they don't get the right answer, they don't feel humiliated. You know, they want to feel emotionally safe also. Each student has access to personalized learning and is supported by qualified, caring adults. One of the biggest protective factors when dealing with students is that they have a supported person or a caring adult in their life. That's one of the biggest protective factors that they can talk to about anything that they need to. The fourth one is each student is actively engaged in learning and is connected to the school and the broader community. And again, that's another big protective factor, is that students feel a connection to school and the community. And when they feel a connection to school and they feel a connection to community, that's a huge protective factor. And the last one is each student is challenged academically and prepared for success in college or further study and for employment and participation in a global environment. So we engage them, and we want to challenge each student to reach their fullest potential, whatever that may be. And so here's Maslow's hierarchy of needs that we talked about. And Maslow said, you know, before we can reach our maximum potential, we have to have our survival needs met, we have to have our safety needs met, we have to have our love and belonging needs met, and our recognition needs met. And those follow very nicely with the 5 tenets. And so you can see healthy, safe, supported, engaged, and challenged. And if kids are feeling each one of these things, then again, they're going to be able to reach their maximum potential. The white ring that we're looking at now is coordinating policy, process, and practice. And so again, you want to make sure that you're looking at your policies and making sure that they're inclusive of all students, not just some. We want to facilitate awareness of the issues. We want to leverage resources, again, within the school and within the community. And then we want to reduce program duplication and fill in gaps. Again, if we have each one of these components talking to one another, then we can reduce that duplication and we can fill in the programming gaps that we have. So again, coordinating policy, process, and practice is very important. And then the last thing is the community. And you see the community surrounds the school because the school is part of the community. And again, this is looking to the community for, again, various resources that you may need. You know, you may go to your local health department if you're in your hospitals, if you don't have health services and you need, you know, a school nurse in the building, maybe, you know, one time a week or 2 times a week or something like that. Maybe you can negotiate with your hospitals to provide that school nurse for you. Businesses, again, can provide a variety of resources. Your social service agencies can provide you with social workers and psychologists and counselors. And then Parks and Recreation, again, we would just want to make sure that our kids have access to healthy activities within the community. We want to work with law enforcement. We want to keep kids away from law enforcement and away from that prison, school to prison pipeline. And then churches can also be very helpful in getting messages across about healthful living. So the community becomes a very important part of supporting the school. There is a WSC implementation guide. If you are interested in doing this, it is step-by-step guidance for districts and schools, and it's put out by the National Association of Chronic Disease Directors. And basically there are 6 steps that you can go through, and the first one is to focus on administrative buy-in and support. If you don't have administrative buy-in, things aren't going to go very, very far. So it's important for you to describe the importance of the whole child to your administrators if they don't already know. Identify a WSC coordinator and WSC team leaders. Ideally, it would be nice to have a person from each one of those 10 components in the WSC model. Assemble a district and school team. You know, this can be at the school level or the district level. Of course, I'm an advocate for doing it at the district level, so all of your schools are on the same page and are trying to do the same things around the whole child. Number 4 is assess and plan WSC efforts. And again, we're going to talk about a couple of tools that you can utilize to do that. And then you implement your plan and you reflect, celebrate, make changes as you need to. But again, go back and you know, what's going well, what's not going well, what did we do, what did we didn't do, those types of things. And so this is another Think in Ink. Just take a couple minutes and think about the 10 components of the whole child model. And again, remember, those are all components that are usually in your schools already. So don't make it too hard about thinking about what those 10 components are: health education, physical education, nutrition services, school nursing. And then think about the 5 tenets also: the healthy, safe, supported, engaged, and challenged. What programs, policies, or practices do you have in place in your school that contribute to your understanding of the WSC model? So we want you just to take a couple of minutes, think about those components, and think about what types of programming you might have in those components and how they might add to our understanding of implementing the WSC model. And so take a couple minutes to do that. And let's just take a look at the next slide, because this is really what we're talking about. If you take a look at the health component, you might have the Michigan Model for Health, for example, as your curriculum, your health education curriculum. Some of you might have Second Step as your social emotional curriculum. Some of you in elementary schools might have bucket fillers. All right. So again, think about what types of things and look around each one of these components, and you can see that, oh yeah, you know, or you may not even know that you have some of these programs in schools, but when you start these conversations among all of the other components, you know, physical education is going to say, yeah, we do have a planned comprehensive curriculum. Do you have planned recess, you know, where your kids go out and they, you know, they can get off all of that energy that they need to get out in a planned recess. But again, just take a look at each one of these and fill in the boxes as you see fit. And then you'll see, what I hope that you'll begin to see is where you might have some gaps and where you might have some duplication of services. So we're going to show you a brief video right now. This is again from the National Association of Chronic Disease Directors. And this is an introduction to the WSC model. So let's take a quick look at this video.
Health and wellness are an integral part of what we do because we see what we do as being key to kids being academically successful.
The whole school, whole community, whole child model, or the WSC model, is our approach to addressing health in schools. It's student-centered. It focuses on the connections between health and academic achievement and the role that the community plays in supporting the school. There are promising practices, but there's no prescribed approach on how to use it. It's going to look different in each school because each school is going to determine what their unique needs and priorities are. I really hope that the viewers will be inspired by these stories shared and access the many resources available to them as they try to make their environment healthier for their children.
Oftentimes is that people think we have to decide between health and wellness and academic success. I contend, and our school district would contend, we can do both.
And so that's just a brief introduction, and you know, a school saying that we really take the whole school, whole community, whole child model into our practice on a daily basis through a variety of programs and practices. And so now we're going to ask you to go to your tiny URL and select a case study from the participant folder. You have two to choose from, Frisco or Thomasville. And what we're going to ask you to do is to identify, read through the, the brief synopsis of what the school has done, identify strategies or steps the school took in order to incorporate the whole child model. Just take some notes on your ahas or key takeaways that could be brought back to your district or your school, and consider how you might share these takeaways with stakeholders. So we're going to give you some time to read through the case study. And again, they're usually 1 or 2 pagers, so they're not very long, but just identify some strategies or steps that the school took in order to implement the whole child model. And so we'll give you a few minutes to do that. And, you know, I apologize. If we were live, we would ask you to share those with us. But this makes it a little bit more difficult. But again, hopefully you were able to pick out some strategies, number one, that they did, and strategies that possibly you could implement in your school also. I want to go ahead and talk about the needs assessment tools that we can use. And the first one is the HSAT, the Healthy School Action Tool. And the second one is the MIPHY, the Michigan Profile for Healthy Youth. And so let's go to the Healthy School Action Tool next, I believe. And this is the main dashboard of the Healthy School Action Tool. We ask that first, you look at the main dashboard, and you can see that there's an HSAT school core. We usually, when we're working with schools, we ask that all schools do the HSAT school core component. And so you can see that there's a healthy eating assessment, there's a physical activity assessment, tobacco, nicotine, safe school environment assessment. So that's your school environment and your school climate. And there's your social emotional health assessment and your staff wellness assessment. And so you can take any or all of these assessments to see where you are in each one of these components. And these are some of the questions. The nice thing is it really does get down to the nitty gritty of what you've got in place. And so in physical education and physical activity, for instance, do you offer 150 minutes a week for elementary schools and 225 minutes a week for middle school and high school students? And what opportunities for physical activity are provided to students before, during, and after school? These are just a couple of the sample questions that you may see in the HSAT. Moving forward, we would go to nutrition, environment, and services. Does the staff model healthy eating habits? Are healthy options offered at concession events? Do students have access to water throughout the day? Is breakfast provided? Do you provide healthy classroom parties and rewards and fundraisers? So again, just a few questions that are asked in that nutrition component that may lead you to developing some more policies and programs that meet those requirements. Looking at health services, do you have a school nurse? And is your nurse ratio 1 to 750? Maybe you have a school-based health center. Maybe you have a mobile dentist program or a flu shot clinic for staff and families, especially during this pandemic. We've seen schools step up to make sure that our staff and students are immunized. And what partnerships do you have with community resources for healthcare for students? Again, I said earlier, if you don't have a school nurse, can you reach out to your local hospitals or health departments and collaborate with them on providing you a school nurse that can be in the building a few days a week? Counseling and psychological services, again, do you have a school counselor, social worker, psychologist? Do they have these recommended ratios of one school counselor to 250 kids, and so on and so forth? And what partnerships do you have with community agencies? If you can't afford to hire a counselor, can you communicate with one of your community agencies to have counselors and social workers come in to work with your students? The next component, social emotional climate. What strategies do you use to strengthen relationships between students, staff, families, and communities? Do you have good relationships? What supports are in place for students that are most at risk? Youth in poverty or your LGBTQ students. What are some of the at-risk student groups in your buildings and classrooms, and how do you identify them? So again, how are those relationships in your school between everybody? Because relationships are a key to academic success also. Then we get into the physical environment. Is it safe? Physical environment inside and on the school grounds. Is it welcoming and appealing in appearance? Is it welcoming to parents, and to other family members who may want to come into the school and experience what's going on? And then employee wellness. And again, we go back to the blobs. And this is, maybe you can start your meeting with the blobs to find out where everybody is on starting this new school year, again, in the midst of a pandemic with masks, no masks, 6-foot distancing, all of that sort of stuff. And then do you have a staff wellness committee? Where again, maybe you have after school yoga for staff, or maybe you have an in-morning walking program for staff, or a lunchtime walking program for staff and students, but what types? Again, we're not just worried about kids' health, we're worried about employee health also. And then family engagement, which is critical. You know, we have to include our families in the schooling process. And what does your school, how do your school and families work together? How do we make sure that families feel welcome in the school? Do they feel like they're a partner in their child's school success? And how do we engage families? So again, we want to make sure that we're engaging families and making them part of this educational process, again, for the academic success of their kids. And community involvement, who's at the table? Does your school collaborate with community agencies? And there's a list of community agencies. And are the school and families also engaged in the community? Again, the school is the hub of the community. And so, you know, how can we get the community more involved so that they support our schools and we're sending, you know, consistent messages to kids? And then finally, health education. Do you have a pre-K curriculum that is comprehensive, developmentally appropriate, sequential, and evidence-based? And the Michigan Model for Health is all of those things. And so I encourage you to look at a comprehensive curriculum. And the Michigan Model for Health happens to be a pre-K-12 curriculum. And if you are interested in that, I am the person that you would go to look at that. But we often find that health education in elementary schools is hit and miss. And we find that our kids are more successful the earlier we start. So if we start in elementary school with health education, we're going to find that our kids are more successful as they get into the middle school and high school. Moving back to the HSAT, and again, those were all questions that come from the HSAT. This is the type of scorecard that you'll get. This is a healthy eating environment, and so you can see where you scored, where your school scored the highest, and where they may need some help. And so this health education, this health eating education and promotion is at 38.6%. So maybe this is where you want to spend some of your time. Going to the next slide, it's also nice. The HSAT is nice because it gives you your green areas as to where you're doing really well, your areas where you're partly achieving, and then your red areas where you're not achieving at all. So you can look at each one of these and say, oh, you know, geez, okay, we're doing a good job in this area, you know, but let's take a look at some of these blue areas and red areas and what can we do to move those into blue or to green. The MIPHY, the Michigan Profile for Healthy Youth, is another tool that you can use. This is a student survey. It usually opens every 2 years. Because we've been in the pandemic year, I think that this is going to be another MIPHY year because we didn't have a lot of schools taking the MIPHY last year because we were at home. It surveys grades 7, 9, and 11, which is nice because we get a middle school snapshot as far as what kids are doing in middle school as far as risk behaviors and protective factors. And we're also looking at the same cohort of kids by looking at 7, 9, and 11 also. Please know that there are two types of the MIPHY or the MIPHY Basic. I always encourage schools to take the MIPHY. The MIPHY Basic excludes sexual behaviors and the mental health and suicide questions. And if you don't think that your kids are sexually active and or having thoughts of, you know, are stressed out and having thoughts of suicide, I think you're being very naive. So this is why I suggest that you take the whole MIPHY, which includes those sexual behavior and mental health questions. It's available every other school year, usually the even years, but it's, again, that varies. The nice thing too about the MIPHY, and what's important to remember, is that we do the YRBS, which is the Youth Risk Behavior Surveillance System also. That gives us national and state data. The MIPHY gives county data, which I'm able to see and other people are able to see, but it also gives you specific school and district data. So this is actually telling you what your kids in your district are doing. The nice thing about the MIPHY also is that once you close out the survey, the data is available in less than a week. This is what the MIPHY reports look like. This is what it measures. Alcohol, drug, tobacco, violence, suicide, weight, nutrition, physical activity, and sexual behavior. And then it looks at risk and protective factors at the individual, peer, family, school, and community level also. And just to point out that these are the 6 CDC risk behaviors for adolescents. In other words, if we're going to teach kids about risk behaviors, these are the 6 that we should be focusing on, because these are the 6 that are usually responsible for premature morbidity and mortality in our students. It aligns very nicely with the tenets. So you can see health and safety, the MIPHY indicators: bullying, aggression, suicide ideation, attempted suicide, overweight and obesity, physical activity, and substance abuse. And if you want to look at engagement and support, it looks at academic participation, co-curricular activities, commitment to doing well in school, perceived support from teachers, and quality relationships with peers. So the MIPHY indicators go very nicely with those whole child tenets from the ASCD. This is what your login will look like. If you look up in the upper right-hand corner, you see Get County Reports. So you can always get the county reports. But when you log in, you need a MEAS account. But when you log into here, you will be able to get your school-specific data, not just county, but your school-specific data. This is what the reports look like. You can see percentage of school students who reported sort of easy or very easy to get alcohol. And you can see 64% said it's pretty easy to get alcohol. In 9th grade, 57% of the kids said it was easy. 71% of the kids said it was easy in 11th grade. And it's also broken down by male and female, and by Black, white, Hispanic, American Indian, and so forth. Now you'll see in this one, American Indian isn't reported out. If there are less than 10 students, they will not report that information because it will be too easy to identify those students. So again, remember, this is an anonymous survey that kids can take in a class period and get it done. And you guys get, again, district-specific data. And your MIPHY data can help you determine the direction of prevention programmings in your school or district. So again, do you see, where do you see gaps in your WSC model? Where do you see gaps in your MIPHY data? If you're seeing it's very easy for kids to get alcohol, maybe you need to discuss that with kids. Why is it so easy? Where are you getting it? That type of thing. And again, that health education component, that comprehensive health education component we want to pull out. And again, we want to make sure that health education is pre-K through 12. The one requirement for health education in the state of Michigan is 1 semester at the high school level, which is not enough. If we taught any other subject like that, math or reading, and you just had 1 semester of math or 1 semester of reading and you were expected to be proficient in it, I would think that we would have a lot of non-proficient kids. And again, I just want to talk about the Michigan Model for Health briefly. It's evidence-based, comprehensive health education curriculum. It is on the NREP and the SAMHSA registries of effective programs. And it's effective for the prevention of risk behaviors and the increase of protective factors. And so this just shows there was a 4th and 5th grade evaluation of Michigan Model Health outcomes. And as you can see, we had better interpersonal communication skills, social emotional skills, and stress management skills, pro-health and pro-safety attitudes, which is important, stronger drug and tobacco refusal skills, and so on and so forth. Fewer incidences of aggressive behavior in the past 30 days. Reduced intention to use alcohol and smoke cigarettes. So again, we did do an evaluation of the Michigan model, and basically what this is saying is if you implement the Michigan model with fidelity, it is going to do what it's supposed to do as far as improving attitudes and behaviors.
So as Dr. Cook has shared all of the components of the WSC model and the tenets of the WSC model, we want to think about our data practices and how we can address the needs of our students in our schools and ensure that we are able to fill those gaps because we are using sound data collection practices and making really sound decisions. So we're going to begin with a quick video of this basketball player. So,
oh, you got lucky that time.
There it is, Fed. That will not make the highlights.
Threw the ball into oblivion. Crowd got a kick out of that.
What on earth was that?
So oftentimes when we look at data, as Dr. Cook has mentioned, we're really only focusing in on the cognitive, right? And we oftentimes focus in using really high stakes data, such as like an MSTEP or SAT, PSAT score. So if this example really represents only looking at one piece of data, right? So if we were to take this one snippet of this professional basketball player's game, this one shot that he made, and he missed really, really, really badly, it doesn't really sum up that entire player, right? It doesn't sum up the things that he does on and off the court on other days. But if we were to use this one event to base all of our decisions on this player, we'd be going down a really, really dangerous path, right? And so when we talk about data practices and the whole child, we're really looking beyond just one test score or just only focusing in on those cognitives. We really want to make sure that we are looking across the needs, including those social, emotional, behavioral, even those mental health pieces as well. So this is why we really want to collect information so that we can really get a complete picture of our school needs, of our district needs, and of our student needs. So we're going to give you an opportunity to do some thinking and inking yet again. And so we want you to consider the data points that you know as a school or as a district, or even as a classroom teacher that you regularly collect. What do you track? And then how do you think those data points align? How might they align with the WSCC model? We're going to give you a moment to think and ink about these two pieces. And so in school systems, we have a wealth of data available to us at our fingertips, right? Oftentimes it is that academic data that we often look to, but we also have demographic information that we collect on the regular within our schools and districts. And this is really descriptive information about our school community, and the students that we serve. So in our demographic data, you probably can tell the number of students that attend your school or district. You probably know their race or ethnicities. You might even know if they receive special education services, if they're on 504 plans, or if they receive English learner services. Depending on your level of access, you might know if they receive free and reduced lunch or if they're socially economically disadvantaged. We have some the academic data, which really, those are the results that we gain from those standardized tests. Sometimes we collect grade point average information. Sometimes we look at our common assessments and the progress that we have towards mastery of standards on those assessments. Or sometimes it's even things such as screeners that we do at the beginning of the year at various checkpoints throughout the year. We also often collect perception data within our schools, and that really helps us to get an idea of what parents and students and teachers and other stakeholders, how they feel or think about our learning environment. And oftentimes perception data, we'll ask people to take these surveys, and then sometimes schools don't know what to do with that data. And so we want to be mindful that when we do ask our families and our teachers and our students to engage in these surveys, that we intend to use those results to make some sort of change. And then our last piece of data, our last type of data, is that process data. And process data is one of the hardest ones to collect because we often don't think about our own processes for doing what we do and why we do it. And so some of these things could be looking at how we program, the instructional strategies that we do, our process for around homework or attendance, or how we select or do certain things. And again, this can be really hard at the classroom level because oftentimes teachers aren't thinking about how they're doing it. We just do it. But as a school or system level, we really want to make sure that we have a really clear picture of how we do things, because this really impacts the coordination of all of our services. And if we know how we're doing things, we can help to prevent those gaps and redundancies. So as I mentioned before, we regularly collect our demographic data. We have a lot of achievement and outcome data, but it's the process and perception data that we maybe don't think to collect as much, especially thinking around that process data. So as we look to thinking about the various points around the whole child, we want to really be mindful that there are other things that we might want to consider. Are we looking to collect information around that social emotional learning? Do we administer screeners to our students around their SEL? Do we collect information about staff wellness and their health and well-being? Are we looking at our school safety, our culture, or our climate? Do we have information or data around the professional supports and resources that are available to our students, to our teachers, and to our families and the larger community? What does our family and community involvement or engagement look like, and how are we collecting information around that? And then lastly, are we thinking about that access and opportunity piece? So many times schools will offer things, but no one will come. And it's not that they don't want to come, because there is the opportunity to go to these things, but do they have access? Meaning, do they have like transportation to actually get there? So lots of things to consider as you are thinking about the whole child and your data collection practices. I like to use this chart here because this chart offers a lot of different ways to think about data, and maybe some of the ways that you might not be collecting data. So typically, we collect a lot of that academic information around standardized test scores, but are we collecting information on school safety plan? Do we collect information, or are we looking at our data around our staff retention rates, or do we have high turnover our staff, and why? Are we looking at our preschool enrollment and asking questions are who is coming but who might not be coming, or who isn't able to come? Are we looking to see who's volunteering? Or maybe if we can't get volunteers, why can't we get volunteers? So this is a nice chart to expand our data collection practices, and it really connects nicely to the 10 components and the tenets that Dr. Cook has mentioned. This chart is available in your resource folder, so you will have access to this. But as we begin to look at our practices and really coordinating, getting people talking, we want to make sure that we have our stakeholders, different stakeholders at the table. So when we're engaged, when we've collected our data and we're getting ready to look at our data to make some decisions about our data, who's at the table? So you want to make sure that you're building a comprehensive data team. If it's just teachers, we have a very narrow scope if we're really looking to do some systems work. Not that teacher voice isn't valuable, but if we're really looking to support the whole child, we're going to need other people at the table. We're going to need some leadership. We're going to need our educators. We're going to need our food service, our nutritional service folks. Transportation, because that can help with access and opportunity. Our human resources. Finance. Some of these things might cost money, but we might have places in the budget where we can make some change. What about maintenance or facilities? And then what about our extending beyond the school and involving our parents and our community? So that could be community agencies like churches, it could be the health department, it could be clinics, it could be nonprofits. But when we have everybody at the table, everybody has their lens, we can really make some sound decisions so that we can make some systemic change and put some goals into place. And when we have this team together, it really allows us to have a laser-like focus on what it is that we're doing so that it can impact our school community. So when we have this data culture, this collaborative data culture, it really helps us to engage in those productive conversations around data and then making some decisions on how we're going to actually proceed. And this happens because we're engaging in a deep exploration of data and analysis of data. And it's okay that maybe not everybody at the table is comfortable looking at data, but everybody certainly has something to contribute to the actual goal or outcome in mind. But the best part about creating this data culture is really building that collective efficacy. And once we have that collective efficacy and this belief that as a team, we can do this work and we can really make some change. So when we engage in this intentional data analysis, we're really having a conversation, a reflective conversation while looking at data. And this helps us to create a shared understanding about what the data is telling us. And it helps us to develop some work and some thinking around the whole child that's thoughtful and intentional. It also helps us to create that ownership, that it's not just my data because it's the academic data that I bring to the table as an educator, but that it's our data and we own this data as a school community. But this also helps us to lead to some collaborative planning, some collaborative problem solving and collective action because we're all working towards the same goal. When Dr. Cook had her slide around the nets, when we don't have all of those pieces connected, our components connected, we're really operating in silos. And when we operate in silos, we can't have collective action because we're all working towards a separate goal. But when we can combine our efforts together, we can really create some change and some movement and momentum around one singular goal that will impact the whole child. And so we often center this idea of collective and collaborative data analysis around the use of a data protocol. And there's lots of different data protocols that can be used. There's data-driven dialogue, and there's variations. And you don't really have to be an expert, but when we have a data protocol, it really allows us to engage in a structured conversation. And this helps us to prevent that solutionitis or this idea that we're going to throw everything at the wall and see what sticks. Just throw out a bunch of solutions and see what happens. But that we're really digging deeper to find a root cause as to what we're seeing in the data and why, so that we can make some action and really fill the need. I often relate the solutionitis as to like putting a Band-Aid on a wound that's really hemorrhaging. It'll stop it for a bit, but soon that Band-Aid's going to leak through, and you're going to have a problem. So when we avoid that solutionitis and we seek to understand the root cause of problems, we can really, really make some change and solve those root causes because we're really crystal clear about what's causing them and we have an idea of what we can do about it. But a data protocol also allows all voices to be heard, and this is really important. So even if we have finance and nutritional services at the table and we're looking at academic data, they can certainly lend their expertise to the conversation. It also allows all users at any level to engage in the conversation because it's not so rigid that you have to be a psychometrician to understand the information, but it allows for some flexibility where we can really dig into information and data that we understand. And it allows the team members to really ask those challenging questions. Because we're coming together on a regular as a team, it's not just we have to get together and look at data because research says that's best practice. No, we're regularly engaging in this so that we can continuously progress monitor our action steps as it relates to our end goal. But because we come together often and because we're building this collective efficacy as a team, we are able to ask those challenging questions of what we see in the data and why. And then lastly, a data protocol really helps teams because it's a time saver. It doesn't, it's a structure that allows us to work through multiple sets of data, but in a structure that doesn't allow us to go off on tangents or go down roads or paths that don't have anything to do with what we are meeting about. So this really helps schools and teams and stakeholders to maximize their time. So some things to consider as you collect your information. How do you currently establish your improvement goals each year? Are they done in a silo? Do you have a team? Are you looking at multiple points of data? Are you considering the 10 components and the 5 tenets? How does that currently happen? Who's in charge of examining your school or district data, and what points are you considering? If you're only considering your academic points to make some decisions, we're missing out, and we're not going to get very far if we don't have those other needs met, because it does certainly impact those academic pieces. Do you have time? Do you take time? Do you regularly engage in data analysis? Are you looking at data regularly? Who's involved in it? Do you have teachers involved in looking at the data, or are you bringing other stakeholders to the table and considering that team, that collaborative team? And then what data points would you consider to know if students are healthy, safe, engaged, supported, and challenged? So starting to think about those pieces. And what programs or initiatives do you currently have that support this? Dr. Cook has said multiple times, you probably have some things in place. But what do you have? Do you know that that is in place? Or are there things at a district level that are happening, but maybe not necessarily happening at the school level? So when you prepare to collect our information or our data, we want to consider the areas in which we have a lot of data in. And oftentimes that is our demographic and our academic, right? And then thinking about how that relates to the whole child indicators. But then what are those areas that maybe we don't have a lot of information around? Where might we need to start collecting our information? I like this third bullet because it's who has access to the data. Is it just, do we have like a gatekeeping type of data lockdown, or do people that have access to it and need the data have access to it? Do you have a data warehouse that maybe has permission levels depending on who needs what? Or are you storing it on paper? Do you have a spreadsheet? But who has access to the data and where is it kept? And then are they currently on your data team? And then what considerations might you need to make as a result of the pandemic? So all of these pieces, as you think about collecting your data this coming school year, these are all things that you want to consider. So in the folder, using the tiny URL, we've created a data practices self-assessment. And teams can use this tool to self-assess your school or district data collection practices. And they're ranked into different categories. So there's a data warehouse category, there's a data collection category, a teacher training or a stakeholder training category. So there's various categories that you can go ahead and rank yourself if you're fully implemented, partially, or maybe not yet. And using this data practices self-assessment tool can really help you to look at where you need to strengthen your data practices so that you can make some goals as it relates to your school or district-based practices around the whole child. So really considering some areas of strength in there, because all schools collect data, but there might be some opportunities for you to strengthen those practices. And then what supports might you need from RISA? What supports could Dr. Cook and I provide to you around collecting data around the whole child? So this is the full template. And again, it is located in the tiny URL participant folder. So as you go through it as a team, really thinking about those potential challenges, and then thinking about the areas of opportunity or some action steps that you might take around those pieces.
And again, we just want to go back, and health and success in schools are interrelated. We can't deny that at this point. And schools cannot achieve their primary mission of education if students and staff are not healthy and fit physically, mentally, and socially. So again, this quote from the National Association of School Boards in 2000 recognizes that connection between health and learning and health and success in the classroom, academic success in the classroom. When we're talking about this stuff and implementing the whole child model and data collection, we're in it for the long haul. And a lot of this is systems change. And so don't expect to see, this is going to take 3 to 5 years. before you're going to see maybe some academic gains that you can attribute to your whole child goals and strategies. But please don't think that within 1 year you're going to see things change drastically. This is systems change and it takes some time. The whole child goals and strategies must be equally as important as the academic goals in the school improvement planning process. So we're hoping with the new MICHIP process, this continuous improvement process, that you will take the whole child goals into consideration, because MDE has taken the whole child and put it in that MICHIP process. So again, when you're going to your school improvement planning process, please make sure that you're thinking about the whole child and not just the academics. It has to be, the whole child has to be incorporated into your mission, vision, and the beliefs of the school. So again, maybe going back and revisiting those mission, vision, and beliefs of the schools, and what are your core concepts and your core beliefs. And then there must be a buy-in from the entire staff, especially leadership, to be the most effective. You can't just go through the motions. And so, talking to your staff about the whole child and what the importance of it is. And again, not just that academic portion, but the social, emotional, and mental health of the student also. And we need to involve and collaborate with the community, like I've said before, to help identify resources needed to address the needs of your students. So again, we know how funding is for schools, and we often have to go to the community to find resources that we may need within the school. So this is just a quick think in ink again. What is one key takeaway that you have from today's session? I just want you to think, is it, did you learn more about the whole child model? Did you learn more about data collection and what you need to do? And what's one tidbit of information that you want to share with a colleague or take back to your school and start the conversation? Because that's what we're hoping, is that this PD will help you start the conversation around the whole child and around data collection for the whole child. And unfortunately, we can't take questions, comments, or concerns at this point. We apologize for that since this is an in-person session, but we would be happy to do it at a later date in person if you would like us to. And again, this is our contact information. My name is Cynthia Cook, school health consultant, and there's my email and phone number, and then Heather Rottermond, who is the assessment and instruction consultant. And there's her email and phone number also. And so please contact us if you would like any more information on the Michigan Model for Health, on the HSAT, the MIPHY, data collection methods, any of those things. Please reach out to us, because that's what we're here for. Again, healthy students plus healthy schools equals academic success. We can't make it much easier than that.